So this is a nice short case.
That's not connected to anything, unless you want to just like, this one is if you want.
Just like a mouse
Oh,
or
that's,
something.
oh, that mouse doesn't work?
I don't see it like showing.
Oh, here, let me see it. Oh.
Something moved. Ooh, move the batteries down.
All right, I just replaced it.
Oh.
All right, go ahead, we're awesome.
All right, so this is a 71-year-old man. In
Okay.
July, presented with a 2-day history of new floaters and flashes in the left eye. There were no retinal tears. 2 weeks later, the patient came back with no changes in symptoms. And some history in November of 2018, and he had a MAC-on retinal detachment repair with vitrectomy and laser. His past medical history otherwise is benign. His medications include pravastatin, propafenone, and aspirin. His visual acuity is 20 OU, and his IOP is 17 OU. All right.
Was the RD repaired to the left eye? Like to the eye that's having floaters and flashes, or?
No, it's the other one. So this is the left, right eye had the RD repair, and the left eye's got this lesion.
Okay. So colored fundus photo,
Yeah,
left
not a lot of slides. Go ahead.
eye, we see this kind of patch of pigmentation inferiorly, kind of surrounded by like a more pale color as well. The vessels do look a little bit attenuated, I would say, especially inferiorly. And can't tell if there's any like elevation or subretinal fluid or schisis there. But we'll keep that in the back of our head and maybe get a OCT of that area. Maybe like chirpy like in its appearance. And you're trying to show me something.
I know, he's trying to follow you.
Oh,
Yeah, I'm just trying to follow.
can't tell if that's like a sclerotic vessel, like overlying that like pigmented, yep, exactly. So maybe like a old,
I think if you follow that, it does look like it turns into the vessel. Isn't there a close-up of that? Maybe, there you go.
Nice.
okay. So zoomed in view, so more of the same. I do think those kind of correlate. Oh, it kind of looks like it's a branch from that vessel,
Yeah,
like a ghost vessel. And then again, we just see these kind of pigmented patches, maybe surrounding, subretinal fluid or just pallor in general. Maybe a little bit.
what about right there where it keeps?
Oh. Okay, sure. Hence the floaters and the flashes. So maybe like a little tear there with some elevation, little heme.
Can you guys
At the
hear it?
edge.
Is he talking loud? You're pretty close. You guys can hear it, can't you?
Yeah, we hear him. Excellent. That was really good. So there's really only 2 pictures. So you pretty much nailed it all. So the findings would include that. There's a tear. Some looks like this might be a ghost vessel, might just be some white lines on whatever pathology you think this is. And maybe some elevation to the retina around this border that I'm highlighting. So what's your differential?
So certainly a retinal tear causing these acute onset floaters and flashes.
No, it's a different
The
thing.
fact that there's some sclerotic vessels and some just pallor, makes me think about like an old BRAO that might have happened and kind of made that area prone to a tear developing, and then the pigmentation kind of suggests like a chronic nature to it, so something might have happened in the past.
And what if a patient presented with this, but without this retinal tear? You just see this on exam. Maybe there's no elevation. Does this kind of resemble any other diagnosis that's pretty typical?
Yeah.
in patients in periphery?
Yeah, so like lattice, which you'll see in like the periphery, which makes you prone to tears developing.
Awesome. Great. So peripheral retinal tear, lattice degen, RD, retinal tuft, chirpy, retinous cases, you hit them all. So lattice degeneration, risk factors. So 6 to 10% of the general population has some sort of lattice degen. 33% of myopes have lattice degeneration. And whenever you get a rhegmatogenous retinal detachment, there's a 20-30% chance that they have lattice as well. In one study, 0.7% of patients with lattice developed clinical retinal detachments, and there are some associated hereditary vitreopathies that are associated. Stickler syndrome is one. You get this radial perivascular lattice-like degeneration, as well as Wagner syndrome, and we'll review these as well. So lattice degen, it's a localized round, oval, or linear shaped retinal thinning that starts occurring. There's some pigmentation associated with it, but not all the time. You get this whitish, yellowish surface flecks, and some linear white patches as well, which sometimes could look like sclerosed vessels. It might be sclerosed vessels. You can also get these round, oval, or linear red craters as well. And the way I saw it,
Our
sorry?
patient had these little craters, I think, the little red, I hadn't heard those red. You think there's, maybe on the left? Oh, those little circles over the pigment. You think those are craters? Maybe not. Aren't those little circles to the right a little bit? Aren't those little circles? Yeah, I thought maybe those were craters, but.
Dr. Cohen,
Yeah.
those little white lines, is that almost like a snail track? Or not?
Which ones? The what? Those are
white lines
vessels.
that we thought were the vessels.
Yeah,
Okay.
those are sclerotic vessels.
Okay.
Yeah, if you follow the vessels, like if you follow those, you'll hit a vessel.
Mhm.
And the way they crisscross is supposed to look like a lattice.
Okay.
So that's a way to remember it. It looks like lattice work.
Sorry, is that just for like the perivascular lattice, or if you have it in the far periphery and you see that kind of scissoring thing, is that also?
Yeah, it's vessel.
Sclerotic vessel?
Yeah, yeah.
But why are these sclerosed? Like what's the?
Over the lesion, it's congenital. Why are they sclerosed? I think that's probably what the lesion is. I don't know.
Yeah,
It's a retinal thinning.
the definition lattice is, there are two components, necessary components, one retinal thinning, and the other component is abnormal vitreoretinal adhesion on the edges of the patch of thinning.
Yeah, so there's not adhesion in the middle. So I think that's just because I think that's the lesion is just the thin sclerosed.
You get your tears on the edges of the lattice.
Right, like in this patient.
Yeah.
Okay, go ahead. Thanks.
And this vitreous liquefaction overlying the thin retina, and then you have just like Dr. Pavin was saying, you have that vitreoretinal adhesions on the borders of the lattice degen. And I highlighted this one because I've seen this. This is how they explained it on the OCAPs. They didn't say lattice degen; they just said vitreous liquefaction overlying the thin retina. Two mechanisms for retinal detachments would be atrophic retinal holes in less than 0.3%, and a retinal tear is more common at 17%. And so, quick review of the vitreopathies. So Stickler syndrome, it's progressive vitreopathy. It's autosomal dominant associated with COL2A1. I think I saw this one before in questions associated with Stickler syndrome, so it's good to memorize the collagen. And plus, if you guys remember, collagen 2 is the most common type of collagen in the vitreous, and it's a vitreopathy. So congenital megaophthalmos is associated with Stickler syndrome, and you get this radial perivascular retinal lattice degeneration type of look. The other one is Wagner syndrome. It's also autosomal dominant. It's associated with the VCAN gene. I think you have to know that. I don't think you have to know it's chromosome 5 on the long arm, but definitely VCAN for Wagner. You get this optically empty vitreous on slit lamp exam with avascular vitreous strands and veils. And if you get an ERG, it's the full field ERG is attenuated. I've been getting some ERGs lately just to see if I can read them. And they're all attenuated. I don't know if it's our instruments, if it's or if it's just if it's me as chief resident. I like to blame everything else. But
I have a question.
uh-huh.
Quick, what does optically empty vitreous actually mean? Like I see that phrase all the time, but I don't understand what it means since vitreous in theory is clear if it's there. What does optically empty mean?
It's a challenge. So when you're looking at eyes, this happens with me because people don't know their history. So when you're looking at the slit lamp, I like to try to see if someone's had a vitrectomy before, because sometimes they won't know. Like I had a retinal detachment, I had lasers, like, did you go to the OR? No, but then they have a cataract. It's like, I don't know, it looks like you had a vitrectomy with gas. It's like, no, I never did that. And So you can look with slit beam and see if the vitreous is there, if they've had a vitrectomy versus not there if they haven't had a vitrectomy. The vitrectomy eyes is kind of what Wagner's looks like. So you don't see it much. So if you look with a slit beam, you really don't see much vitreous there. You know, they talk about these strands, but I have had actually in the last, I haven't seen Wagner's forever. And then the last couple of years I've had a couple with Sticklers and a couple of Wagner's, and you look in, it's actually similar. You expect to see the vitreous kind of behind the lens and
Yeah.
smoking around, and there's really not much there. And you can't do the indirect, you have to do
The
the
slipping,
slit
yeah.
beam.
Yeah, and so there's different methods for treatment depending on what type of lesion we're talking about. So if you have a horseshoe tear, you've got to treat promptly, and I believe this is all with laser. If you have an acute symptomatic or percolated hole, treatment may not be necessary, and that's the case pretty much with all operculated holes associated with it. But I think a lot of doctors would, for an acute symptomatic one, would put a couple laser markings. What would you guys do?
I go back and forth. I tend to treat it. If it's acute, I tend to treat it. I don't think it's necessary. It's super easy, but yeah, if it was my eye, I'd probably want to treat it.
Yeah, that's fair. And same with dialysis, treat promptly with any type of traumatic retinal break. You usually want to treat an asymptomatic horseshoe tear. Consider treatment unless there are signs of chronicity. If it looks chronic, it's got the pigment on the outer borders showing that it's tacked on its own, then
Yeah, it's
asymptomatic.
just the thing with an asymptomatic horseshoe tear is I had an asymptomatic vitreous detachment, like totally asymptomatic. I scan my retinas once in a while just to see what they look like because I don't feel like going to the doctor. And and somewhere in the last 6 months, I had a PVD in one of my eyes, and I know so an asymptomatic horseshoe could be an acute PVD just because the person didn't notice it, which is interesting.
You got lucky.
Yeah, I got examined. I had to pick which of my partners. I won't tell you which one I picked. It was a challenge. I have to have someone examine me. I don't want to insult anyone. No.
So other than horseshoe tears, pretty much everything that's asymptomatic really doesn't need treatment. And so most doctors would just watch pretty much all types of lattice unless you've got something symptomatic or if you have that horseshoe tear. For the asymptomatic dialysis, no consensus as well. And eyes with atrophic holes or lattice degen where the fellow eye had an RD. This is, I think, something where it might be on the boards. There's no consensus on treatment, insufficient evidence, but I've heard a lot of doctors do like to put lasers around. If the other had an RD, is that the case, Dr. Cohen? Or
I
Dr.
was I just was reading this paper. I usually didn't, but a paper came out in Retinal Journal. Oh gosh, when did this come out? This came out last month, 2024. It was out, I think it was Wisconsin. They had 498 patients, 148 had prophylactic treatment and 352 had no prophylactic treatment. These are fellow eyes of eyes that had retinal detachments. They found that the prophylactic treatment had significantly fewer detachments. They had 17% in prophylactic detachments and tears. They had 17% in the prophylactic treatment and 41% in the no prophylactic treatment, which is high. So actually I sent that to my partners and Scott tore it apart and didn't like the paper. And so it's actually even among our group, because I thought this was pretty compelling. This was 2013 through 2017. It was a pretty big study, and they looked at PVD, myopia, pseudophakia, all that stuff. So they showed a significant reduction in fellow eye detachments with laser to lattice. But I have to say, the one thing you look at these numbers are really high. So 41% fellow eye tear detachment rate is pretty high.
Was
But,
it a retrospective or prospective
This
study?
was retrospective, and they looked at a pretty big group, and I think it was a Wisconsin group. Yeah, who was running there? Ryan, which of the Ryans? There's a Ryan in the paper. Ed Ryan, where's Ed Ryan? Do you know? I forget. Anyway, he's a famous one. Well, Ryan's got the textbook. He's dead, not Ryan.
Yeah.
So, but anyway, so that paper to me almost made me want to laser more. So I tend to not treat fellow eyes, but now I'm thinking maybe I would treat him a little more based on that paper. But my partner thinks he would not. That was in Retina Journal. I think it was this month's Retina.
It used to be that people would treat everything, and it was before laser and cryo was used. The Retina Associates would do surgery and put in,
Oh,
diathermy
on the
around.
old days.
Yeah, that's a big thing. I
Yeah.
mean, that's an invasive,
It fell up the
Yeah.
lattice.
but Norman Byers or Byer.
Buyer, I think it's buyer.
Yeah, he is passed, but he was in California. He was in, one of the well-known towns,
Down San
where they,
Diego.
where they did the Spirit of St. Louis,
Somewhere
they
in
built
San
that.
Diego.
Bakersfield. He
Okay.
practiced in Bakersfield. And, he has a beautiful atlas. I have it. And, it consists of, 35 millimeter slides. Remember those? And, he would follow lesions, asymptomatic lesions for years, and nothing would happen. So he was really instrumental in you can observe many things
Yeah,
without having to treat.
the tough thing, which you mentioned already, the statistics, but the two statistics that are tricky with lattice is a third of retinal detachments are from lattice. So, but only, oh, do you have it, but only about 0.7%, but then that's the thing, so 33% of detachments are 30% are from lattice, but only fewer than 1% of patients with lattice develop retinal detachments.
Yeah.
So that's the thing, so if you just, before that second number, Bayer came up with that 0.7%, that was his work. So before that number existed, people looked at the 30% number and thought, oh my God.
Yeah.
You know, all this lattice degeneration, we gotta stop the detachments, but it turns, that's why it's important to look at statistics both ways. So,
Yeah.
go ahead.
And if you do a laser for the fellow eye, do you do like a barrier laser around the lattice, or do you laser the lattice directly?
Barrier.
Back around it.
Barrier.
Yes, 3 to 5 times around it.
Sweet.
And technically, so my understanding is that reduces your risk of detachment by about 50%. This is what I tell people. If you laser the lattice, it reduces your risk of detachment in the eye by about 50%, because about half the time people will tear away from the lattice. So you don't get it, but you can do 360 laser. 360 laser reduces the risk of detachment more, but then the thing with all that laser, you're burning bridges. Retinal detachment surgery is not that big a deal nowadays, but if there's a bunch of laser in the eye, it can be very hard to get successful.
It's also hard to see the tears.
Yeah, so what I always tell people is like trying to make, reattaching your retina is like trying to make your bed. And you're trying to fluff it and smooth it out, and if the lasers are all little attachments, it makes it hard to really smooth it. So those are my patient discussions. So I don't like laser in general, but that paper was interesting.
Yeah.
As one of the criticisms for that paper, was it that for the sham treatment or the observation arm, the sample size was about double the laser arm?
No, they were both pretty big sizes. One was they didn't have the extent of the lattice account. Like, why did some of them get treated and some of them not get treated? I don't know, the extent of the lattice was a concern, and also that their numbers were kind of high. It's, you know, in both groups, and that's the, you've taught, Reed, I never heard of it until Reed told me. I never heard the word publication bias until you mentioned it in a meeting once. And I didn't even know what it was, but publication bias is when you're working in a group and you get a lot of things happen to your patients and you think we should write a paper about that. And so you get this group where they had a lot of fellow eye detachments. They thought, well, I wonder if the laser to the lattice helps. And so they publish it. And that's publication bias, because there may be something weird about that cohort. So it may not be reflective of the whole world. Like, I've had that happen in my group. We'll look at something with macular holes, or like, we should probably, this is kind of weird. Like, we've had 5 patients with, you know, this happened to them. Maybe we should publish it. And it gets in the literature and people start thinking it's generalizable, but that's why some retrospective stuff, and that's called publication bias. And that was one of the things with this paper. The numbers were a little high in both groups.
All right. So for treatment wise, like we were mentioning earlier, treatment for lattice with or without retinal holes, unless you have a tear, at which point you could do the standard focal laser, 200 microns, 440 milliwatts. I guess Dr. Cohen did 213 pulses, 70 microseconds, yellow, green, rod and stock lens. I've been liking the rod and stock lens. The retinal tear should be surrounded with a minimum of 3 concentric rows of laser. And so these are some images from that same very patient. It's same day, then 2 weeks and 3 months later. So here's that same day and 2 weeks and a few months later after that.
And it's interesting because the laser spots go from light to dark. So there's this in-between time where you can't see them. It can be a little stressful, especially if it's not your patient. Like, you guys see each other's patients. So you're looking at somebody, you think, did they get the laser or did they miss it? That middle one can drive you a little crazy. So you just have to have faith in your partners. And the other thing, I had a call once from a former resident, if you're lasering, and Sam, I can't do this here, but if you look at the tear, if you put a pointer on the tear, let's say you're lasering where I lasered, a little bit away from the tear, and you're not getting takes, and then you go farther out from the tear, and you're still not getting any takes, and then you're like, I'm trying to laser this, but I can't get laser takes. Why is that happening? Yeah, there's fluid, so that means there's a retinal attachment, you're just not seeing. So you just gotta keep marching out. I wouldn't go toward the macula, I would maybe go sideways until you get a take, because it may be just that you're screwing up and your settings aren't right. Because you don't want to keep going, but in general, as you're lasering these things, you can kind of find the fluid, and you can see here where there probably was, like, I have a little cuff here on the bottom and a little cuff around here, and that probably was a little bit of fluid at the time. So I just kind of march my way right from the tear, laser, get a take, and then circle it, and then circle outside that and inside a little one. That usually covers it.
The interesting is that, who was the sponge guy in New York?
Oh, Linkoff.
He looked at how adhesions form under cryo.
Yeah,
When you do cryo, you don't start to get an adhesion until about 2 weeks.
right.
And so
I
you really
thought-
done nothing for 2 weeks.
Right.
And yet they don't detach.
Right.
In the
I
majority of
thought
cases.
laser too. I thought laser didn't adhere for a week or two. You mentioned that it might.
Laser, I think, will create a very minor adhesion right away,
Right,
but it takes a week.
yeah.
So you get faster adhesion with laser. So if you can,
So I restrict the patients for a week from, jogging, jump roping. I had a patient with a massage chair. That was weird. I kept doing retinal attachment surgery, kept coming off. It was actually, this is really strange. I don't think it's totally inappropriate. They were like an 80-year-old couple. It was about 10 or 15, maybe 15 or 20 years ago. And the reason it sticks with me, I did the pneumatic, she detached. I think I did a vitrectomy, she detached. And then the husband looks at her and says, they were an English couple, and says in my office, maybe you shouldn't be using your vibrator so much.
Oh my God.
And
How old
they
was
called,
she?
they were in their 70s or 80s,
Good
and they
for
called
her.
their massage chair, they called their vibrator. Which is really cool. So I was like, so what do you have at home? They said, we have this massage chair at home. I said, oh, okay. Interesting.
Dr. Cohen, did you read about, there was an article, I want to say maybe a couple months ago in one of the journals called Massage Gun Retinopathy. Did you read that
Oh,
one?
yes, I did. There was a psychotic patient. I think it was a photo in the Ophthalmology journal. It was a patient who had the psychotic. I showed it to my kids.
Yeah, he like just used a massage gun because his eye was bothering him
on.
on his eye, caused retinal detachments and bleeding.
Yeah. And he
Beverly
was just, yeah, crazy person with a massage gun. Yeah, I saw that. That was good. We have one of those. I told the kids, no.
We had someone at the VA who came in with a hard